cancer survival. And so there certainly is a basic science justification that this might be something that can work against cancer in general. So really, at least from my perspective, the story really kind of begins when there was a study that was published back in 2013. And what they did was they took over 50,000 patients who had diabetes, and they looked at which ones were taking metformin and which ones were not taking metformin, and to see how many of them developed prostate cancer. You would think that it shouldn't matter if you're taking metformin, you should have equal risk of getting prostate cancer. And what this slide is looking at is what are the chances of you getting prostate cancer if you had metformin? And if there was no effect, the result should be a 1, which is right on that line between the shadow and the white. And you can see that there's many trials where the black box, which is where most of the patients fell, there seems to be maybe a slightly protective effect that people who took metformin have in developing prostate cancer. Now, it wasn't true in all these observational studies, but if you take it as a whole, there certainly looked like there could be something here. And really, this is just an observation. It's really hard to make definitive conclusions, but I think this is something that is what we call hypothesis generating, and certainly something that would be in need of further investigation. So this goes back about 11 years ago. And then I think what was even more intriguing was the data that I'm showing here. And this is data from Memorial Sloan Kettering in New York. Dan Spratt, who's very well-respected prostate cancer doctor, he's a radiation oncologist, he's now in Cleveland. What they did was they took all their patients at Memorial Sloan Kettering who they treated with radiation for early prostate cancer, and they looked at who was taking metformin and who wasn't taking metformin to see what happened over time. And on the left-hand side, this is a curve of how long did they stay free of cancer. And you can see in the solid blue line that the people who took metformin, it looks like not very many of them had recurrences. But if you looked at the diabetics who were not on metformin, and that's the red line, the dotted line, a lot more of them had their cancer return. Those differences are huge. And then if you look on the right-hand screen, this is people who are dying from prostate cancer. And certainly it looks like metformin, many, many fewer men are dying from cancer who happen to be taking metformin, but the diabetics who are not on metformin had a much higher death rate. So this was looking backwards, so that's called a retrospective trial. And so this, which was also published in 2013, really opened up the door of, my gosh, could there be a pretty simple way that we can have a positive impact on this disease? Now, it could be that this is all from metformin. It could be some kind of coincidence. It could be maybe the people on metformin just take better care of their health and they have follow-ups more often. And the people who don't take metformin don't really care about their health. And maybe it has nothing to do with metformin at all, but maybe it does. And so this was very intriguing, but certainly nothing that was conclusive. So a little bit later, because of this, everyone else got very excited and wanted to, can they reproduce these studies? Maybe we need, what else can we learn from this? So this is a study that was published several years later. This now goes up to 2017. And this is from the folks at Fox Chase in Philadelphia. And so what they did, they looked at a lot more groups and looked at things a lot more carefully. So they took people who also had radiation to treat their prostate cancer, just like the group at Sloan Kettering. But they didn't just look at people who were on metformin versus not metformin. They looked at people who were on insulin. They looked at people who were on metformin. They looked at people who were on a different drug than metformin, and another oral drug to control their diabetes, or people who didn't have diabetes at all. And then they looked at several different parameters. They looked at how long did it take for the PSA to come back, PSA rise we call it, or biochemical failure. How long did they live? And there's a lot of graphs here, but the takeaway message here was if you had diabetes and you didn't control it, you clearly did much worse. And that's the red lines. Probably the best one is the one on the top right, which is freedom from biochemical failure. But if you didn't have diabetes or you had diabetes, but you were controlling it pretty well, you were controlling with insulin, or you were controlling with metformin, or you were controlling it with some other oral drug, they all did about the same. So this study suggested that, well, yeah, if you control your diabetes, you do better, but it may not necessarily be metformin itself. And so that's what I basically just concluding here. From what I've told you, the observational studies, as I said, there could be a protective effect of metformin in developing prostate cancer. Certainly in retrospective studies, the Memorial Sloan experience looked like metformin was very protective, but a second study from Fox Chase suggests it really was just controlling the diabetes, not the metformin, that was responsible for this difference. But of course, none of these studies are prospective. None of them are looking forward. They're all looking backwards. And so people then said, well, we really have to start looking at prospective trials. And there's so many different places you could do the studies. You can combine it with ADT when people are getting hormone blockade. What about if you combine it with when people are getting chemo? What about some of these new drugs like enzalutamide? And so people started looking at adding metformin in all of these different situations. And before I get to that, I just want to say that one of the problems with some of these trials that you'll see is that the trials are all really small. And when the trials are really small, sometimes it can be really hard to get definitive conclusions. And that's what has sometimes made a good interpretation of these studies difficult. Also, by the way, I'm not presenting every study that's done. I'm just trying to show the key ones. So some people may be aware of some other trials, but I try to at least get at least the larger trials to discuss. So anyway, so this first study, it was a study where they took people who were getting androgen deprivation therapy. So these are people who had typically advanced prostate cancer. They were castrate sensitive, and they were getting ADT. And what they did was half of them, they gave them metformin, and half of them did not get metformin. It was a very small trial. It was only 36 people. And they really only followed them for 28 weeks, which is like 6 months. So really not very long. And really what they looked at was, did their PSA become undetectable or not? So very limited study. Again, small, short-term follow-up. But what they found was 50% of the people on metformin had an undetectable PSA by week 28, and 53% who didn't get metformin. So essentially, no difference. Does this prove anything? It's hard to say. All it proves is that a drop in the PSA, 28 weeks later isn't any different. But it's one of the few prospective trials that we have. The next study, which actually is a retrospective study, it wasn't a prospective study, but what they did was, this is data from Ontario in Canada. And so they looked at all these people who were had gotten chemotherapy and looked at who had been on metformin and who had not been on metformin. And they really didn't see any difference at all in how well people did with chemotherapy, if they had been taking metformin or not. Again, it was not a very big trial. but seemed to suggest there really wasn't a clear benefit, at least in that population. Obviously, these are people who have quite advanced prostate cancer. And then probably the best trial, this is a prospective trial. It hasn't actually been published, but it's been presented at a meeting. The big meeting that I presented was at ESMO, which is in Europe in 2022. And what they did was they took people who had castrate-resistant prostate cancer. Everyone, as you can see on the schematic here, if you start at the left, everyone had progressive disease on ADT. Everyone, which is standard, is that you continue the ADT. And then one arm, which is arm A, they got enzalutamide or Xtandi, and with metformin, or they just got the enzalutamide by itself. And again, one of the limitations of this trial, it was fairly small. They only had about 80 to 85 patients in arm A and in arm B. But what they saw is on this slide, and so the blue line represents people who are getting metformin, and the kind of grayish line is the one where they did not get metformin. And on the left-hand side, that is a graph of how long they went before they had disease progression or any other event. And you can see that the blue line is sitting above the gray line throughout the entire course of the 60 months. But if you look at statistically, because it's such a small number of patients, it didn't reach what we call statistical significance. So we call it a trend towards better outcomes with the metformin, but not necessarily a true difference. And then on the right-hand side was the time it took before the PSA began to progress. And again, you can see that the metformin arm clearly seems to be doing better than the non-metformin arm. But again, if you look at it, the statistics, because you're looking at a small number of patients, that did not reach what's called statistical significance. So that could be a real phenomenon, or it could be just better by chance. It's very difficult to tell. But that's one of the few well-controlled trials looking at metformin that at least suggests that metformin might be doing something. So far, we've said that in prospective trials, there's no clear benefit of metformin in advanced cancer, but certainly in some of the trials, there's a suggestion of a benefit. And this was in castrate-sensitive disease, in castrate-resistant disease with chemo, or castrate-resistant disease with enzalutamide. Now, I think what a lot of people were talking about, well, this is all more advanced cancer. Maybe metformin really has a good role in very, very early prostate cancer. Maybe it's going to make a big difference there. And so there's been a lot of intrigue on this, and there's been a study that's been going on called the MAST trial, and I'll get to that in a second. But that was just reported, those results, last month in Chicago. There's an annual meeting called ASCO, and that's what I'm going to talk about next, this MAST trial. So this is how the MAST trial works. If you look on the left-hand side, these were all patients who were newly diagnosed with what we call low-risk prostate cancer. They all had Gleason 6 or less. They all had a PSA less than 10. So these are all like the classic patients that typically they have early prostate cancer, but they don't necessarily need treatment. And all of these patients were going on active surveillance. And it's a reasonably sized trial. There was 2 arms. Arm 1 had 203 patients. Arm 2 had 204 patients. And they all were under active surveillance. One group got a placebo, and the other group got metformin. And they all had prostate biopsies at the beginning, They had prostate biopsies at 18 months. They had prostate biopsies at 36 months. So they were all watched very carefully and followed over time.
Quick question, Dr. Mannion.
Yeah.
This is Ethan Bulgarian. The dosage they got one 850 milligram pill for 1 month, then followed by, what is BID? What is
Twice a day. I'm sorry, twice a day.
Twice a day. So they got double, they had 2 pills a day for most of the trial.
Correct.
Because the trial went on for quite a long time, right?
It did. It went on for 36 months, which is one of the few trials where the metformin was looked at over an extended period of time, unlike some of these earlier trials where just very, very short follow-ups.
The reason I ask, and I don't want to interrupt it too long, but some people claim that the direct influence of metformin on like AMPK is dose dependent. So, because in all those mouse trials and so forth, those mice got a big whack and big dose of metformin, while here, 850 or even 2 a day, some people might say, and especially for non-diabetic men, all these men are non-diabetic, right? That it's not enough, that the serum level of metformin is too low to actually have much of an influence on AMPK. I'm just saying.
Yeah, I mean, when you're designing trials, there's a lot of things you have to take into consideration. Now, of course, I wasn't part of the trial, but I think clinically, one of the problems that we run into when people take metformin is certain things like diarrhea, which can be a problem. Some of these patients get vitamin B12 deficiency. So it's not completely innocuous. And to convince people to take this for years, sometimes you have to modify things so that people actually take it. But anyway, this is how they end up doing the trial. So it's a total of what, 17, after the first month, 1,700 milligrams a day, which is actually for people with diabetes, that's a pretty good dose. Anyway,
Sorry. Okay.
So what they found is the following. So what they did was they did biopsies and they looked at people, did they reach a point where they needed treatment? And they looked at people who had a progression of their prostate cancer to a higher Gleason grade. And these are the results that they showed. So all the way on the left-hand side is the sum of people who either progressed based on the Gleason score going up or progressed to the point that they needed to start treatment for their prostate cancer. And you can see the metformin, which is in the red, and the placebo, which is in the blue, pretty much were the same. They really didn't look like there was any clear difference between the people who were getting metformin and the people weren't. And then if they just looked at progression pathologically, that means, the Gleason score went up. Again, it looks like there's no clear difference between the two. And then if you look at the therapeutic progression, again, there didn't seem to be a terribly large difference. And then they...
Could I ask a question about that previous slide?
Sure.
At the bottom, number at risk, it drops off at 48 months drastically. What does that mean? That people died between the 36th and the 48th month, or why is there such a decrease in the number?
I don't know why the numbers drop so much. I don't know if some people dropped out of the trial or I'm not sure. It's a good question. I don't have a clear answer for that.
I was going to say, at least on the graph on the right, which is the one that I can see most easily, the metformin graph stops before the placebo one stops.
Yeah, one's at 48 months, the other extends a little bit more. In fact, in that one, there's even a slight suggestion that the chance of staying free of progression was slightly worse with metformin. But getting back to the number at risk, why it dropped so much, I don't know if the trial stopped at 36 months. So I'm guessing at least the big drop off between 36 and 48 months is that most people weren't followed anymore because the trial was over. But I'm guessing there because I thought the trial was only a 36-month trial.
Okay.
Can I just sorry to interrupt, Dr. Mannion. I believe the way these Kaplan-Meier curves work out is, you have this entire population. By the time you get to the end, they ran out of people. I think that's why the numbers go down, right? So you had 200 and some people in each, by the time, and you're counting for all of them, basically, by the time you get to 48 months. I think that's how I read it, to answer Chip's question.
Okay, thanks. Any other questions about this before I go into a little bit more of the data that was presented at the most recent meeting on this? Okay. So in terms of, remember I showed you the previous slide, all the way on the right, there's a suggestion that maybe metformin was inferior. And so they looked at different subsets of people, and one thing they found was that people who had a BMI, that's body mass index, of less than 30, that means they fell into a non-obese group. It looked like metformin and placebo had the exact same outcome in terms of had been progression of their prostate cancer. But for people who fell into a BMI of greater than 30, it seemed that metformin had a negative effect, which was quite a surprise. And the p-value actually was 0.01, and that is considered significant from a statistical standpoint. Not really clear explanation why, but this was an observation from the trial. And the other observation from the trial is they looked at people who did progress. And when they progressed, did they progress with a Gleason score of 7? Or did they progress with a Gleason score of 8 or more? And they circle here the people on metformin. 8 of the people that progressed had a Gleason higher than 8 or more, whereas the placebo, it was only 3. That does not reach statistical significance, but it was a suggestion that maybe if you progress and you've been on metformin, might be a slightly higher chance that the Gleason score that you progress to is worse. Again, not definitive because it does not reach statistical significance. So really,
Dr. Mannion, I'm sorry to interrupt again.
Sure.
If you could go back one slide. I actually was quite interested in this conclusion, but you know what, I listened to his presentation. I think he was interviewed by, anyway, and in the interview he mentioned that, the study started in 2013, way before people would get MRIs, right? So how do they know these people all had Gleason 6s? It was mostly by random biopsy. And so the chances of missing a small Gleason 8 tumor were there, while if they had MRIs, pretty good at picking up Gleason 8 tumors, right? But many of them never had an MRI. So this could be just statistically a fluke, right? That maybe for some odd reason, those who were taking metformin in that group, maybe there were more occult Gleason 8 tumors to begin with that just weren't seen. I'm right. So it's really not definitive.
I absolutely agree. It's not definitive. It's
and the only real surprise
definitive.
is the thing about the BMI over 30. That is a surprising result. And Dr. Joshua wasn't able to explain that.
I don't think anyone can explain it, but it's certainly thought-provoking. I'm sure going forward, if people continue to study this, they're going to be looking at that, I'm sure.
I want to bring up something with respect to what Ethan was just saying, and a few slides back. He was asking about was it 800 or 850 milligrams twice a day? I was just prescribed metformin today, which I thought would be a good thing to do, but they're only offering me 500 milligrams once a day. And it might be like, that it's so small that it has no effect at all. that's measurable. How did they come up with the 850 twice a day? And when you look at this slide that you have on the screen, how much metformin were these people taking?
So in this trial, they started off with 850, and for the first month, then went up to obviously 1,700. I don't know why. I mean, I would agree that 500 is probably too low. I do not know how they came up with that final dosing. Again, I'm assuming that they probably said they want to do the maximum dose possible. That still has few enough side effects that the majority of people will take it. But it's a little bit of guessing on my part. I don't know if it was based on, biochemistry, or if it was more just like a practical kind of conclusion. It's a good question, though.
Yeah.
Have there been any tests done where the various arms of the test had differing amounts of metformin to see if that made a difference, or where it might actually make a difference?
To my knowledge, I'm not aware of any trial that has looked at different dosing. I mean, it's hard enough to get any trial in this particular arena. Unfortunately, if there's no one trying to sponsor a study, it can be hard to run the study because of the cost involved. And that might be one of the reasons, but gosh, it would be great to have a trial with varying dosing.
The other thing I wonder is, I mean, metformin on label is actually a diabetic drug. Using it for prostate cancer is, I think, what they call off label. Could it be that the 850 is what's normally given to a person who has diabetes?
So with diabetes, I would say the most common dosing is 500. Most people go up in groups of 500. So 500 or 1,000 or 1,500. Those are kind of the typical doses that most doctors taking care of diabetes would give. But there's a bit of variability.
Can I again throw in a couple cents here? I think that's true. The typical dosing is suppose people start with 500, and if they do well and don't have too many side effects, then they go on to 1,000 and 1,500. I think 1,500 for people who really need it, but I think it's also depending on how their body responds to metformin. They look at glucose levels and HbA1c and all that stuff, right, Dr. Mannion? So I think typically they want to start them low, and because of the side effects, mostly diarrhea and stuff like that, and then if they progress, most people progress to more. And so I think this is right in the ballpark. They obviously don't want to give people, but in the mouse studies, they give those mice, much higher doses, and I think they did see a dose dependent impact on both for good and for bad of metformin. So.
Yeah, certainly in the diabetes world, what the doctors are trying to do is give it the lowest dose possible for effectiveness. So they don't really have any incentive to push the dose unless the diabetes is under control. And then if they can't control it on 1,500, they have so many other options to turn to. So I think the most I've ever seen anyone take for diabetes is about 2,000. I don't think I've seen anyone take more than that.
Yeah. I hate to keep bothering you, Dr. Mannion, but I've been on metformin for the last 6 months, not so much to treat my cancer, but to treat the side effects of hormone therapy, which are many and varied, and the metabolic consequences of ADT are, your glucose level goes up, your cholesterol goes up, and of course there are other effects. So I managed to persuade my PCP to prescribe metformin, and man, it's done wonders for me. My glucose level has gone down from like 99 to 78, and cholesterol level has gone down, and bilirubin has gone down, creatinine levels went down. Just a miracle drug on one 850 pill a day. So I don't know what it's doing for my cancer, but it's doing great things for the rest of me.
Yeah, I'm not aware of trials looking at just relief of side effects, but certainly what you're saying makes a lot of sense based on how the drug works.
Yeah.
My situation is the same. They have me pegged at pre-diabetic. I'm just a little bit outside the norm, but the glucose is always a little bit high because of the ADT that I'm on, especially the prednisone, the abiraterone, the what's the other one? The Xgeva, the abiraterone. So I'm hoping also that by bringing my glucose down, it might actually have a positive benefit on my prostate cancer as well. Oh, and let me ask Ethan, what's your dosage, by the way?
One pill a day. And I'm not diabetic.
No,
I
but
don't,
how
you
many
know,
milligrams per day?
850.
Okay. They only started me at 500 today.
All right, Jeff, very interesting discussion. So I think the bottom line is, should you be taking metformin or not? I think right now there's no clear downside of doing it. Certainly if you're feeling better and your sugars are better, I don't see any harm in doing it for most people. Whether it clearly improves the cancer situation, I think really is an open question at this point. We have some trials that show maybe there's a benefit, some trials that show there may not be a benefit, and that's kind of where we are at the moment. I know I've taken a lot of questions, but I'm happy to take more questions, or even if there's questions about prostate cancer that aren't about metformin, I'm happy to answer those as well.
Well, if you don't mind, I mean, if anybody else wants to come up first, I can wait. But I actually started doing some investigation online. So people might ask, what's Google worth? But these come from the NIH and the NIMB. And what they were saying is two professors at Columbia University in New York have discovered that there's a link between the NKX3.1 gene and people that have an underperforming version. It's related to mitochondria, that metformin might actually have a positive benefit for them, but others whose NKX3 gene is working correctly, the metformin doesn't seem to make very much difference. And I did have the genome test in a year ago, and we looked back up at what genes I was actually tested for, and the NKX3 is not even in there. It's just like people, if they don't have the BRCA gene, having a PARP inhibitor really doesn't make very much difference. And I'm wondering, have you heard about this connection between this particular gene and the performance of metformin?
No, I mean, I'm familiar with the gene in prostate cancer, but I was not aware that there's some data saying that maybe those folks have a particularly, positive effect to metformin. But that's interesting. So that's out of Columbia, you said?
Yes.
Okay. Yeah. I'll have to look that up.
I'm interested. I was interested in metformin for a long time, because I was in 2019. I had a Foundation 1 test of my biopsy samples, and it showed that I have alterations in PTEN and P53. And since PTEN controls the PI3K pathway and AKT and then mTOR and all that stuff, I thought, well, metformin might be a hot ticket. So I started looking into it, and I actually had a correspondence with a Dr. Frigo. He runs a lab at MD Anderson. He's been researching metformin for a long time. And what he's discovered and he wrote a rather interesting paper back in 2017 where he's saying, you know what, metformin can either help, but it can also hinder. In other words, it can be beneficial for prostate cancer, but there are certain cases when it can actually be detrimental to prostate cancer. And he says a lot has to do with it's the impact on AMPK. That's what his opinion. But he says AMPK can be sort of multifocal inside the cell, and that's this impact. He calls it the spatio-temporal impact. In other words, it's when you take the metformin and and all kind. In other words, it's complicated. It's just complicated. And so who knows who's going to benefit and who's not going to benefit, and when you're going to benefit, and at what stage in your prostate cancer, because prostate cancer goes through transitions, right, where metabolically it becomes rather similar at the beginning. It's rather similar to the benign cells, to the well cells in your prostate, and then as it progresses, changes metabolically, right, and becomes more like other cancers, which are driven by glycolysis and so on and so on. So you think that metformin might impact the later stages of prostate cancer more than the early, which is why I'm a little surprised that Dr. Joshua decided to pick on early stage prostate cancer for his trial. So to me, that's kind of doesn't make a lot of sense that it would have much of an impact there, but who knows? So anyway, it's, I think, a fascinating subject. I'm so happy that you brought it up. I'm kind of wondering, my question to you, Dr. Mannion, is were you somewhat influenced by this latest presentation at ASCO, that it sort of has a kind of brought metformin up to the forefront in the oncological world?
Well, I mean, let's see. I guess it's, it's never, it doesn't really advance the field when you have a negative study. But I would agree that, this is only one setting, and this is the setting where the prostate cancer is the least abnormal behaved. So you're taking, you're taking the situation where it's least likely to work and hoping it works there. But I think the positive thing is it's one of the very first trials that was randomized, that used metformin, that was presented at a large audience, very mainstream kind of audience. And so I think it's, if nothing else, it's bringing at least the subject of metformin very much to the forefront, which in that part, I think is good.
I have to say, I also found an interesting coincidence. NPR recently had a, whatever they call it, that there's some possibility that it might actually be an anti-aging agent. And they said one of the problems is to find funding for a real study. Since the drug is now generic and no pharmaceutical company can make a great profit on it, the money comes up short to actually fund the study. Pharmaceuticals only want to fund studies on products that they can exclusively sell. So it was said, at least.
I couldn't agree with you more. You would hope that there'd be equal, attention to drugs, no matter, what their origin is. But yes, that's a real challenge with a drug like this.
Is it metformin basically for diabetes?
Yes.
So you're saying that it will assist in prostate cancer coming back?
So yes, so metformin has been on the market for a long time for control of diabetes, but then potential off-label use is possibly for prostate cancer based on some of this data that we talked about tonight. And so there's a lot of interest in, could metformin change the trajectory of prostate cancer, and does it have a clear role in our toolbox to treat prostate cancer, even though it was originally intended for diabetes. And we have a lot of examples where there's drugs that came on the market for one reason and then end up being used for other reasons as well. So this happens not infrequently.
Would it assist you or help you if you had the prostate removed?
I'm not aware of any trials looking at metformin after the prostate's removed to see if it lowers the risk of it coming back. I did show some studies looking at using it after radiation to try to prevent the prostate cancer from coming back.
Trying to keep your PSA low, or
Yes, well, that's what a lot of these trials are trying to look at. Will it do those things? Again, the limitations, which we've kind of discussed tonight, is the right dose being used? Is it really a high enough dose that's been studied? The trials are small, so if you don't see an effect, do you really want to conclude that it won't work just because your trial was so small? You may not have seen the benefit. So that's why I think really the jury's still out on exactly how well does it work and where would it be used best and at what dose should it be used. These are all unanswered questions.
You would recommend it for pre-diabetes?
Yes. I mean, if someone has pre-diabetes, I think it's a very reasonable drug to take. It can have side effects, but most people tolerate at least low doses of metformin pretty well.
You mentioned diarrhea. Pretty severe.
It can range from none to severe. I mean, usually, at least to prevent the diarrhea, there's a long-acting form of it. There's like a quick release and a slow release. The slow release definitely has lower risks of diarrhea.
You speak of metastasis or real critical cancer stages. At what point does the medical industry looking at prostate cancer consider that? Is it a high PSA? Is it results from PET scans? What determines whether you're in the critical stage? I had prostatectomy in 2012, January, and it's taken 13 years now to get to 4.69.
Okay.
So it's jumped a lot in the last 18 months. Where, with your expertise in prostate cancer, where am I at in your mind as far as seriousness? Other doctors tell me when I get to 8, I should go into hormone therapy. So I'm trying to learn more about this and what I should do.
Yeah, so the question is, someone who's had a treatment for their prostate cancer back in 2012, and now their PSA is up to 4, over a decade later, how serious is that? And so at least what I try to do, and this is a moving target, try to put people into different categories, because that helps us decide what the best treatment should be. And so for someone who previously has been treated for local prostate cancer and now has the PSAs where you described, the buckets I think of are, I'll kind of go from the worst bucket to the best bucket. The worst bucket would be prostate cancer that you can see on a picture, and that there are many spots. Many spots usually means more than 4 areas in the bone, or you have spots in critical organs, and that would be considered metastatic castrate-sensitive prostate cancer with high volume disease. That'd be kind of the worst scenario. The next bucket down would be you do scans and you have metastases that we can see, but there's not very many of them. It's like just in lymph nodes in the pelvis, or just lymph nodes in the pelvis and up to 3 spots in the bone. And that would be considered prostate cancer, castrate-sensitive prostate cancer with low volume disease. And those 2 categories are treated differently. The high volume disease is usually treated more aggressively, or differently, I should say, than the low volume disease. Kind of the next level down would be you get a scan and you see nothing, and that would be called just a biochemical recurrence. And how you treat that kind of depends, at least in my clinic, on how long did it take the PSA to get where it is. And that's called the PSA doubling time. So if someone has biochemical recurrence and the PSA doubling time is really slow, let's say it's longer than a year to double, I often tell patients, we can just watch you. It's not a very critical situation at all. But if someone has a biochemical recurrence, but the PSA is going up quickly, that's a different scenario, and that usually does warrant therapy. So at least those are the kind of buckets I think of when someone's PSA is now rising after they've had definitive treatment. So I don't know if that helps or if that was too much, but
Well, can a PET scan be performed with a person with a 4.69?
yes,
Is it readable?
it's typically readable. Yes.
Okay. Because I heard if the number's really low, or I've read that they don't even want to do it until it starts rising to a higher number.
Yeah, I mean, different people have different thresholds for PSMA PET scanning. I'd say a fairly common thing that most people agree on is that the PSA is above 2. And it's a very reasonable study to do. Some people do it even lower. But I'd say at 4, it's a very reasonable study to have done if you haven't had it done. I guess any other questions from the virtual audience?
Well, I had one other question. I actually heard first about metformin before the pandemic. I didn't know much of anything about it, but apparently there was a doctor, I believe in the Cincinnati area. His nickname was Snuffy Meyer, Charles Meyer, who prescribed metformin a lot, apparently. I asked my urologist about it, and he didn't feel confident, so he deferred to my PCP. But did Charles ever, Dr. Meyer, did he ever accumulate any statistics or results for the metformin that he had been giving to his own patients?
Yeah, so he actually was in Carolina. I can't remember if it was North Carolina or South Carolina. I think it was North Carolina. I don't think he was actually in Cincinnati, at least during my time in Cincinnati, but there was a lot of people who went to him. And my understanding is he started people on metformin based on a lot of that retrospective data that I showed. I don't know if he actually followed his own patients, systematically and looked at the data or not. But I do agree with you that he did put a lot of people on metformin.
Anybody else have any questions? Online?
I just wanted to add one thing. Thank you very much for this presentation. I really appreciate it. I think everybody does.
Oh, well, you're more than welcome. All right. Okay.
Ethan, do you have your questions? Ethan, do you have your questions?
I'm sorry, can you repeat that? I can barely hear you.
Do you have any questions?
I just want to thank Dr. Mannion. I think this was clearly something that interested me personally. I was worth getting up in the middle of the night to join, and I guess I'm really hoping that could be more careful studies, maybe looking at the genomic profile of these various, the men here. That clearly everybody's different. Could be that some people may benefit from metformin more than others. I was hoping I would, since P10 is such a regulator of these genes that in the cell are very related to progression, also to the metabolism, like AMPK is the master gene of the metabolism. And so one would hope that metformin really should help. And certainly at least can't hurt, but should help by lowering insulin levels, which is insulin is a oncogenic hormone. So there are lots and lots of reasons and tons of mouse studies that show how great it is, and so it's rather surprising that it's not more effective for more men. And but anyway, so I'm very, very grateful to Dr. Mannion for bringing it up. It's we all hope for an $18 a month. For $18 a month, you get a great benefit with very few side effects. Hey, it's going to be a wonder drug, right? And why isn't it? So I'm really looking forward to more studies to show what perhaps some subpopulations might benefit it in a more understandable way rather than just the hit and miss. And so, but you know, unlike the PARP inhibitors, where you know they've identified these guys with mutations in BRCA, and then of course PARP inhibitors are pretty expensive. It's worthwhile spending a lot of money on this research, while metformin is so cheap. So, but you know, so that's a real issue. Anyway.
I don't know if there's any ongoing trial right now.
I think it's a good VA for Medicare.
Do you know if it's for people with very advanced prostate cancer or more early prostate cancer or?
I don't know.
Mhm. I see. So I don't know if everyone like can hear, but there may be a trial at the VA, at the Cincinnati VA, where they're looking at metformin.
Right, because the government might be the biggest beneficiary, right? If it could reduce prostate cancer care, that would be a big incentive to fund a trial with greater power to figure it out. Don't you think so, Dr. Mannion?
Oh, I would agree. I mean, yes, if you look at the amount of money, you know, Medicare spends, if there's a way to reduce that spending on a drug that's inexpensive, it certainly makes sense to me.
Right.
All right. Well, again, I really appreciate speaking here, and obviously always a very insightful audience, which is greatly appreciated. Thank you.
Thank you so much for coming.
Oh, you're welcome.
Thank you.